good?
I was about to say, that's really good.
All right, so don't put this on your belt, but that's live, and I'll check the audio level and adjust it if we need to, but don't hold it right up. It'll be too loud.
Okay. Should we go? Good afternoon. I'd like to welcome everyone this afternoon for our Athletic Training Education Endowment Lecture Series. Our 18th lecture series is sponsored by Mike Strauss. Mike completed his undergraduate degree at Michigan State University and became a certified athletic trainer. He then went to Emory University where he completed his physician assistant and was at the United States Olympic Training Center where he worked with men's field hockey. Mike currently is a PA in the Department of Orthopedics, and he oversees MSU's women's field hockey team. We would like to thank him for sponsoring our lecture series and all the time that he donates to our athletic training program. Thank you, Mike. This afternoon, we are honored to have Ron Courson, who is currently the Senior Associate Athletic Director for the University of Georgia. He joined the University of Georgia in 1995. He completed his undergraduate degree in physical education from Stanford University, where he played both soccer and ran track and field. He then completed his graduate work at the University of Tennessee, Chattanooga, and he also completed his degree in physical therapy in 1989. He is a nationally registered advanced EMT as well as a certified strength and conditioning specialist. Ron has been involved in numerous international and national athletic training activities, including working as an athletic trainer for the U.S. Olympic team at the 1988 Olympic Games, 1990 Goodwill Games, 1987 World University Games in Yugoslavia, 1987 Pan Am Games, 1992 Olympic Games in Barcelona, Spain, and he was also the chief certified athletic trainer for the 1996 U.S. Olympic track and field trials, as well as the chief athletic trainer for track and field for the 1996 Olympic Games in Atlanta, Georgia. He's very active in his profession. He's a member of the NCAA Competitive Safeguard and Medical Aspects of Sport Committee. He is the past president of the Southeastern Conference Sports Medicine Committee, as well as the chairman for the College and University Athletic Training Committee. He served as a member of the DIA Athletic Directors Task Force on Student Athlete Development and currently serves as the NFL Health and Safety Committee. Ron has been inducted into the Hall of Fame for the Southeast Athletic Trainers in 2011, and in 2013, he was inducted into the NATA Hall of Fame. He is very active in research. He believes in research and education, and he's authored numerous professional papers and text chapters. He has also served as lead or co-author with several NATA position statements for emergency preparation, exertional heat illness, managing of sudden cardiac arrest, and management of head and cervical spine injuries. He's currently chairs the National Spine Injuries and Sport Group, and he's developed evidence-based medicine protocols for pre-hospital care for spine injuries. It is our great pleasure to welcome Ron Courson.
Hey, thank you. It's a privilege to be here today. Really excited about it. I've had a lot of good friends from Michigan State for a number of years, and really appreciate the opportunity to be here. Going to keep this really informal, so we'll have some questions and answers during time, and I want to hopefully make this a really good interactive thing. But what I want to talk about today is emergency planning in athletics. And the good news is emergencies don't happen with great frequency in athletics, but when they do happen, we want to be prepared. It's so easy when something has happened very commonly, you get a false sense of security. Well, it'll never happen to me, or it'll never happen to the sport. So really what we want to do today is think about what if the situation happened to me today, or down the road, am I prepared to deal with it? See,
Start with this.
okay, oh, perfect, okay. Okay, what if you're an athletic trainer, and this is ironic right now because it's really cold outside, but I'm from the South where it's always hot. We're in football two-a-days, and the WGBT is in the high-risk category. You have a football player collapses. He's unconscious, responsive only to pain. His skin's got hot to the touch. What are you suspecting? Exertional heat illness. Now, this is something where your decision you make in the next few seconds can make a difference between life or death. And we've got to be prepared. We've got to cool him emergency. And this is not a time where you can say, hey, Daryl, go fill up that cold tub and put 150 gallons of cold water in there. We've got to have a plan to be done in advance. So what would you do in this situation? Because again, the intervention we make right here may make the difference between life and death. You're an athlete trainer at a basketball game, and the basketball athlete makes a winning shot, and there's a big dog pile on the court. When everybody gets up, they find he's laying on the court motionless, in cardiac arrest, no pulse, no breathing, no signs of life. You can see the panic here. Are you going to be the calm, cool, collected person that can make a difference and save this person's life? What would you do in this situation if somebody collapsed? Cervical spine injury. This is actually a case we had at the University of Georgia, and Jeff Wilson is here. His son, Drew, is one of my assistants at Georgia, does a great job and actually managed the head with this athlete. But this literally happened right in front of my feet on the sideline. It's an athlete on the kickoff. We're playing Southern University, and one of their players goes down, and right at the point of contact with our player, drops his head with axial mechanism, literally 10 feet away from me. I'm the first responder there. He looks up at me and says, Coach, I can't move my arms or legs. I can't feel anything. What do you do in this situation? You've got an obvious cervical spine injury, catastrophic indications. There's very limited we can do on the field of play to manage it right then, but how can we effectively evaluate him, find out what's going on, and package him safely for transport to definitive care facility where we have further help? What if? What would you do in this situation? Sickle cell. When people think about deaths in athletics, they think about spine and head and asthma and cardiac. But the reality is, in the last 10 years, we've had 20 Division I football players die from sickle cell. It's the leading cause of death in the NCAA. And the sad thing about it, it's avoidable. But again, knowledge is power. We need to know who our sickle cell athletes are. We're covering off-season workout, and you have an athlete start complaining of dizziness, fatigue, shortness of breath, severe leg pain. You know he's sickle cell trait positive. And then he tells you, hey, Ron, I probably should have told you this before, but I've been sick the last 24 hours. Had nausea, vomiting, diarrhea, haven't eaten anything. So he's a sickle cell trait positive athlete. He came to this workout already dehydrated. Now he's deoxygenated. He's going to sickle cell crisis. Now he's on a continuum right now, headed for something really bad if we don't intervene. What do we do? Because the decision we make right here can make a difference between life and death. Head injury. You're covering a competition with cheerleaders. Cheerleader falls off the pyramid, hits her head on the ground. Obviously, showing signs of concussion. You evaluate her, but about 50 minutes following the accident, her symptoms change. She collapses. She has a blown pupil. Suddenly begins vomiting. Now you're more suspicious of a closed head injury. What do you do in this situation? The objectives for the day are first to recognize emergencies, because we can't treat anything effectively if we don't first recognize it. And that's one of the cardinal issues we see sometimes in emergency medicine is they're missed inadvertently. Well, once we recognize the emergency, how do we treat it? How do we communicate? Because emergencies involve a lot of different people. We may have athlete trainers or student athlete trainers on the field, but now suddenly we have EMS that we may or may have not met before. We have physicians we may have not met before. May not have the same background of training we have. So how do we make all these inter-association disciplines mesh and work well together? How do we document it? Most importantly, how do we review and rehearse for emergencies when they happen? Because practice makes perfect. It's just like motor learning. You know, a team is going to do well because they practice plays. If we have to do an onside kick at Georgia to win the game at the very end, hopefully practice that every week over the course of time so we can execute when we go. So it's not realistic for us to think as sportsmen professionals, if we don't practice and rehearse, then we'll have good results because they're motor skills and we have to practice. And then post-incident critical stress management, not only for student athlete, but for us as healthcare professionals. It's traumatic to deal with an event like this, so to make sure we're taking care of our staff and ourselves as well. Ward Denver is a highly decorated Navy SEAL, and he has a saying, calm is contagious. Calm is contagious. Really has a factor in sports medicine, particularly emergency medicine. If we had that picture of basketball a minute ago, when panic ensued, you have an 18-year-old young man who's not breathing, has a pulse. His mom and dad are right there saying, save my son's life. What do? They're going to look for us to maintain calm. And by the same point, fear is contagious. Panic is contagious. So everybody around the scene is going to take the lead from us in how we project. And again, we may not be calm on the inside. We've got to project calmness on the outside. And how do we remain calm? By practice. Practice makes perfect. So if we practice our skills on the front end and review and rehearse, then we're going to be calm on the back end because we know what to do and we know our plan works. Communication may be the most important thing we think about with emergency medicine. Now again, what makes a great athletic team? It's basketball season right now. If all 5 of my basketball starters want to be the leading scorer, we're probably not going to do very well. Everybody has a role they have to play. We have a common vision that we want to do. So if everybody stays in their lane and plays their role, we can be successful. But again, if everybody wants to be the leading scorer, or everybody wants to have the ball all the time, we're not going to do very well. And the same thing with emergency medicine. We may have a scene where you have athletic trainers, physicians from a variety of specialties, paramedics, emergency medical technicians, event management, police, fire rescue, ED staff. We all have to work together. We all have to communicate. And one of the things we want to think about today is pre-emergency communication. What can we do on the front end that's going to help me on the back end? Now, our goal is simple. We talk about what's our team goal, what's our sportsman's team goal. We want to make sure we have the highest quality health care to every real athlete. So we got to work efficiently. So we have to share information. For example, I've been an EMT for a number of years. But again, I practice primarily as an athlete trainer. And although I spine boarded a number of people, I guarantee I have a spine board nearly as many people as my paramedic crew has. But by the same point, I deal with athletic equipment every day. So if we have a spine injury with equipment on, I promise you I have a lot more expertise in that area than the paramedics do. But we don't want to be contentious. We have to work together and share information. If we do that effectively, then we can have a good outcome. If we do it ineffectively, who's going to lose in that is the student athlete. And that's not what we're going to have. Communication is the first thing. Emergency action plan. I want to make sure we have a good emergency action plan that's one venue specific, because the emergency action plan here for football is going to be different for one in basketball and the one in ice hockey. And even within that sport, you may have different venues. For example, in football at Georgia, we have multiple emergency action plans. I've got one for my sports medicine facility if we had a cardiac arrest inside. We have one for our indoor facility. We have one for our practice facility. We actually have 2 for the stadium, one for we have a game and one we have a scrimmages, because the difference is 100,000 less people. And it changes my traffic flow pattern. So it changes how we're going to take them in and out of the stadium. So making sure we're venue specific for everything we do. Now, the first thing we have emergency action plan, we're all healthcare professionals as athletic trainers. So it needs to be reviewed by a medical director, by a physician, to make sure we're on the same page because we're working at his or her standing orders. The next, and a common thing that doesn't happen, it needs to be developed in conjunction with EMS. And really, if you think about it, that's a common sense standpoint. If we have an emergency, the first thing we're doing is calling 911, and EMS is arriving. So doesn't it make sense to make sure that our emergency action plan is coordinated with them? A great example is spine. I may have a spine protocol that I want to use, but the paramedics come and they're working on a different spine protocol from their EMS regional director. They're bound to follow his direction, just like I'm bound to follow my team physicians, and a conflict may arise. So hopefully we've solved this on the front end and make sure everything meshes. So when we do an emergency action plan, make sure we communicate with EMS. Then the most important thing is distribution. Now, too many times in the past, EMS or emergency action plans get scared of a sports medicine issue. Hey, you all just take care of it. But again, we've got a lot of people on the same page. We've got to make sure we communicate. So one thing we do at Georgia is the first of the year, if we start our sports in August, usually the second week in July, we have a big emergency medicine meeting. And obviously my sportsman staff are there, but I invite fire rescue, police, campus police, sheriff's department, the ambulance service, our athletic directors, our institutional emergency people, Anybody who's going to be involved in emergency, because I want to have them in the room. We can discuss it. We have a PowerPoint. We go through our emergency action plans. We talk about our venues, and then we have input. So maybe fire rescue has a question about a new facility we raised. We can address it right then so we're all on the same page. Another simple thing we do is we make copies of emergency action plan, and we put them in every police unit on campus. Put them in every fire rescue vehicle on campus. We put them in every ambulance in the city. Because again, if I call an ambulance to my house today, a little red light pings up on the board, they know exactly where to go. But if I call EMS to the basketball arena, it's 4 levels and 60 outside doors. So how do they know where to go? And school campuses, whether you're a high school campus or college campus, can be very confusing. So we want to make sure they know exactly where to go. So again, if ambulance gets a call to soccer, they can flip through, they get the book right there that shows them exactly the entrances and exits where to go. So making sure we're doing a good job of communicating effectively. We want to make sure we have a clear system for communication. One thing about athletics, having a backup plan, having an A, having a B, having a C. Great example, if I'm on game day in Sanford Stadium, we've got almost 100,000 people there. We know for a fact cell phones don't work very well. The towers are overloaded. So I can't depend on my cell phone to always work, so I've got to have a backup. Where's my hard line? The same thing in radios. I may get the SEC championship game in Mercedes-Benz Stadium in Atlanta, and we've got radio interference. Say my radios don't work effectively. So I've got to have a backup plan, whether it's physically send a student athletic trainer to get my physician or use the hand signals. But again, on the front end, making sure we've got a backup plan that we talked about, so when we have a crisis, we can remain calm, everything works accordingly. A simple thing right here is just taking a laminated emergency action plan and putting it by every hardline phone. Again, we'd like to think we're going to be calm and cool and collected, but do we know the address for every venue we're at? And there's been some tragedies in athletics, particularly when you go off-site. How many of us have had a time where maybe the fields are in construction, you take a conditioning test in a different place, and you hop on a bus with a team and go there? If an emergency happened, do you know the name of the park? Do you know the street address? Do you know the gates to get them in? So making sure we communicate that. So a little hard plan we have by every phone. The same thing, we have a smaller version of 3x5 laminated card that all of our students and staff carry in their back pocket. So again, I can pull that out, and I've got a template to follow step by step by step. Communication. Communication, when I call 911, is dictated by the information I give them. Now, a lot of times we have this picture in our head. If I'm working emergency, I make that call. They see the same thing I don't. The reality is I've got a paramedic or sometimes just a lay person in a booth, and they're looking at a computer screen in a dark room. So the response they send is dictated by the information I give them. Let's say, for example, somebody collapsed right here, right now, and went down. If I call 911 and say we have a patient on the ground, they're going to send 1 unit. And the paramedics, they really don't know what to anticipate, so they're going to get off the truck with their jump bag. The ambulance has a lot of equipment. I give everybody an example. My dad was a carpenter for years and years, and I started helping him from the time I was 6 years old. So we pull up to a job site. He say, "Hey, Ron, get the sledgehammer, get the reciprocating saw, get the crowbar, get this." We pull the tools out that we needed for that specific job. We didn't empty out the whole truck because that would have been a waste of time. Paramedics do the same thing. They have a tremendous amount of equipment on the truck. They're going to get what they need. So if I call and simply say, I have somebody down, they don't know what to get, so they're going to come initially with a jump bag, do assessment, and then go back to the truck and get what they need. Okay? What if it's a cardiac arrest? Okay? If we let them know without the sergeant, say somebody's down, I have somebody in cardiac arrest. We're doing CPR, we treated AD. A couple of things are going to happen with that. Number one, they're going to be going through that mental checklist as they make that 7, 8, 9-minute drive here. What do I need? What's my ACLS protocol? When I get off, I need to make sure I've got my drug box, I've got my defibrillator, I've got my oxygen, I've got everything I need. So when they come in, they save time. Let's say that same scenario, we just called and said somebody's down, and paramedics come in with a jump bag. They realize he's in cardiac arrest. They've got to go back to the truck, get more gear, come back in. Maybe 2 minutes in, 2 minutes out. We delayed 4 minutes. Now we know for every minute we delay care in a cardiac arrest, that's a 10% decrease in survivability. So just from a poor EMS communication, we just decreased their survival rate by 40%. Another thing about cardiac arrest in Athens, our protocol is if we have a cardiac arrest, they transport 4 paramedics, not 2. So they'll send an ambulance unit and they'll send fire rescue. Again, if I have somebody in a code, I'm working in the back of the ambulance, I'm trying to start an IV, push cardiac drugs, do compressions, defibrillation, back valve mask. One person can't effectively do that because one of your paramedics is going to be driving to the hospital. So again, the information we give them is going to dictate the response. So making sure we give really good information on the front end. If something changes, we can call back or stay on the line and give them more information. But that's the key in emergency medicine is first recognition and then making sure we're making that correct call and giving good information. Medical timeout. In my mind, this is one of the most important things that we've ever done in the NATA. This was initiated back in 2014. And think about the concept of a timeout. We're all in athletics. You know, Michigan State's in a tight basketball game. They're down by 1. They get 10 seconds left. Coach Isso's going to make the play. He's going to call a timeout, bring everybody to the side, get a clipboard, and drop a play he thinks has a high success to win the game. We're going to get organized to make sure we have a good result. That's why we do a timeout. We have physicians in here. Joint Commission requires before every surgery, before the first cut is made, they have to call timeout in the room. And everybody has to stop. The anesthesiologist, the nurse, the circulators, the physician assistant, they have to stop. This is John Smith. He's a 19-year-old white male. He's having an ACL reconstruction. No history of allergies. He's on this medication. We put in 1 gram of Ancef. So everybody's on the same page before they start the case, a medical timeout to be organized so we have a good result. Now, doesn't it make sense before an athletic event to have a medical timeout the same way? Let's call it a quick timeout, get everybody together before the game, before the practice, whoever's there from a medical standpoint, the paramedics, the physicians, the athletic trainers. Let's talk about this. Hey, if we had emergency, level 1 trauma centers down the street, that's where we're going to go. Have visiting athletic trainers. It's a hot day. This is where our cooling tank is, to make sure we're on the same page. And particularly even more from a high school standpoint, because a lot of times in high schools, you may have a paramedic that doesn't know the staff. If you have an athlete go down and somebody runs out in the school windbreaker, they have no idea if you're an athlete trainer, you're a physician, if you're a coach, or you're a parent that came out of the stands. So again, those simple things beforehand can make a big, big difference. This case here really cemented this. This is Devon Gales. Devon was a sophomore at Southern University. We're playing them in a football game 4 years ago. He had that catastrophic cervical spine injury. Well, we don't play Southern. They're not our conference. The first time I met their athletic trainer was immediately before the game in the medical timeout, Lovey Tabron. Lovey, ironically, had been at school for 5 days. She'd taken the job on Monday, and her first game was this game. She actually hadn't met Devon until the time of the injury. The same thing, Dr. Courson, their physician, was a brand new physician. He'd been there for 3 weeks. So not only do we know their staff was relatively new. Ironically, this was right at the time when the new C-spine protocols had come out, and we just changed our protocol. So we introduced ourselves before the game. We talked about our paramedics, where they're located, introduced them. Talked about our trauma center, where it's located at. Talked about the equipment we had, and ironically, we talked about a spine injury. And our protocol at Georgia is to take the gear off, if possible, on the field of play. So we discussed that. Not knowing that 2.5 hours later, we're going to have a catastrophic spine injury. But literally, at the start of the 4th quarter, the first play, he goes down right at my feet. I'm the first one there. By the time Lovey and Dr. Courson come across the field, we knew what we had. Drew to assume C-spine. We'd already started the process. They would come across as their athlete. What would you like to do? We'd like to follow your protocol. It made it very seamless because we talked about before the game, what if we had, and what if maybe they want to do something a little bit different and we had a disagreement. So the medical timeout can make a critical difference in making sure we've got good care. Now, once you have it, we want to implement it. So we want to educate everybody regarding the plan and not just talking about it, but practicing and rehearsing on a regular basis. And more importantly, making it scenario-based where it's realistic. It's one thing for me to throw a spine board out there on the field and practice it one time. But let's practice scenarios. For example, let's do somebody prone. Do somebody prone with their head turned to the side where they're in a neutral position. Let's do somebody supine, maybe in a contorted position. Let's talk about a combative athlete. What if there's inclement weather? What if there's space considerations? We're in an indoor facility and I've got a spine injury against the side where now I can't get people on both sides to lift and slide. How do we react to that? So scenario-based training, if you think about it, that's what we do in sports every day. When we do football practice, we think about scenarios. What do we do on 3rd and long? What do we do in the red zone? What do we do with an onside kick? We practice scenario specific, and that's how we have success. The same thing works in sports medicine. Again, venue implementation, we want to be specific about it. So again, on game day, I actually park my ambulance over here. On a scrimmage, I park my ambulance over here because again, I'm not worried about 100,000 people with traffic flow. Another reason I do this is we have a bridge right here we can lift up, where we can bring trucks into the stadium to do maintenance. On game day, it's closed, but on non-game days, it's raised up. So it actually allows me to bring an ambulance onto the field of play. Our stadium is older, and we can't bring it in because the portals are too low on game day. So again, I have a practice scrimmage scenario emergency plan. I have a game day emergency plan. I have one for indoor facility. I have one for my outdoor facility. Venues need to be specific based upon that and think about how accessibility. For example, if we have a baseball field, if we want to bring an ambulance on the field, how are we going to get it on there? I know that I can't get to the first base line, but I get through on the third base line. A big thing is host. If we're a visiting athletic trainer, it's incumbent upon us to find out what's going on for our student athletes. If I'm the host athletic trainer, it's my responsibility. Like if Sally's coming down to the University of Georgia, I want to communicate with Sally before the start of the week. Hey, Sally, here's our emergency action plan. If we had something happen, these are the hospitals we go to. And if visit her before the game. Hey, Sally, do you have any questions? Make sure she meets our staff. We want to make sure we explore things beforehand. Again, if we prepare on the front end, it's going to help us have a good response on the back end. Emergency transportation. Where do we have it available at? We typically try to have for high-risk sports. What defines our high-risk sports? How do we make that decision? And do we have it for high-risk sports and also for spectators? For example, we may have an ambulance at every basketball game, not because basketball is truly a high-risk sport, but I've got 10,000 spectators there watching as well. How many ambulances do we have? For example, in football, we have 7 ambulances. I have 6 for spectator and 1 dedicated to athlete field of play. Well, what if the athlete field of play ambulance leaves? We're going to rotate one of the spectator over and bring it back in and bring another spectator ambulance in. So making sure we've got a good plan, making sure we've got good ingress and egress. Soccer is one of my biggest problems in Georgia. We have a very small drive. And from time to time, what will happen is somebody will come in a double park and it blocks our ambulance in. So our police have to make sure that our ambulance has good ingress, egress, that road is always kept clear, because what you don't want to have is an emergency. Now I can't get the ambulance out, or I can't get the ambulance in. Nothing in an emergency situation, make sure we transport by ambulance. You don't want to try in a life-threatening situation to put somebody in a car or private vehicle where you don't have the care. What if something happens and I don't have the appropriate care to take care of them? Another thing is thinking about if I transport away from practice or game, who's going to take care of it in my absence? Do we have a plan to make sure that the field is still covered? Maybe it's the first quarter of that game. So who's in charge? If I'm going to the ambulance, or one physician going to the ambulance, hey, you're staying behind, you're in charge now. Do we have a good communication plan for that? Again, it goes back to being organized, having a plan A, a plan B, and a plan C. Special considerations. This is one, and I know y'all got some construction going on right now. We're the same thing. We're building a giant new football arena. Impacts traffic, and not just for football right now. My Coliseum's across the street, so it impacts men's basketball, women's basketball, gymnastics. I've got street closures right now. So making sure, if I have an emergency right now, one of my primary emergency gates for football is a construction site. So it's closed now. So if I make that 911 call, making sure they know you can't come down Smith Street, you got to come to Pinecrest. So making sure we're aware of construction issues, weather issues, traffic flow issues. And this is something, again, you talk about in your medical timeout. And a lot of times people have the concept of medical timeout just for games. Well, I think about for practice every day too. We had a 5:30 workout yesterday morning before I left with the football team, and it's inclement weather outside, and we have construction. So we did our medical timeout. We did a radio check before we started, and we talked about, hey, if we had an emergency, we're going to bring them this gate. We're going to pop the doors into the facility, just talking through it. And again, it's just my staff. It may take 2 minutes. But again, it's when we get comfortable, when we get complacent, that's when bad things happen. So again, just making sure we remind ourselves on a regular basis, the medical timeout is really important. Air medical transport. Again, we haven't done it on a regular basis, but in my career, we've had 4 times we've done air medical transport. Again, where are my landing zones at? Are they indicated on my reaction plan? Have I thought about that in advance? Do you ever practice that? I know Daryl, I consider one of the top emergency guys in the country, does a great job from a practice standpoint, and they do that and review and rehearse it. Emergency care facilities, where are we going to go? I remember with Devon Gales, we transported him to the hospital. And Lovey, their athletic trainer for Southern's in the back of the ambulance. And we drove right by the hospital and kept on going. And she looks at it and says, well, there's a hospital right there. We went a further mile down the road and went to our trauma center. We have 2 hospitals in Athens. The first one we drove by, we could have definitely stopped that, but we didn't have emergency neurosurgeon capabilities there. So we got to think about what the pathology we have and what the best place to take them to. And again, think about that in advance. If I have a cardiac, where am I going to? If I have a burn, what's my closest burn center? What's my closest trauma center? And knowing these things in advance so we can communicate. Another thing is notifying them of impending things. You know, like for example, we've got the SEC swimming and diving coming up next week, and we're gonna have a lot of people there on campus. Let my emergency facility know about that. We're hosting NCAA tennis in May, and we're gonna have 500 people there. It's gonna be hot. And I may have people from the West Coast or from Harvard who aren't used to 90-degree weather in May with high humidity. So let the ED know there may be a potential heating list. On the front end, again, anticipation. Making sure we equip them and develop an emergency action plan. So for example, to start a football season, we do an in-service every year with our ED staff, and we go over with myself and Drew and some other people, and we talk about equipment removal. Now again, you know, most of the time I'm going to remove equipment on the field of play. What's the chance we don't? And now I'm the only athlete trainer over the ED with 2 physicians and a nurse that have never seen a helmet or shoulder pads before, have no idea how to remove them. So we want to talk about this on the front end, and we go through and train and talk about how to remove that. We talk about emergency treatment of healing illness, and again, to make sure we're on the same page. So we can involve our ED staff and our training, it makes a big, big difference. And I found out they really enjoy it and they appreciate it. You know, they want to be the best they can. They want to learn more. They see a lot of pride in our athletic programs, so they really buy into this. Again, what are my emergency medicine facilities? How am I selecting them? And then make sure I'm reviewing it on a regular basis, doing in-servicing with them. Documentation. As my attorney at Georgia says, Ron, if you didn't document it, it never happened. We've got to do a good job of documentation. Now, first on the front end, do we have good emergency action plans? Have we reviewed them on a regular basis because things change? We review our emergency action plans at a minimum once a year. And then we have everybody sit down and have my physicians review them. My EMS reviews them. Legal reviews them. Then if we have an emergency, do we document that? What happened? Exactly. What went good? What went bad? What will we change? Is there anything we want to change our emergency plan based upon this? And again, it may be a little simple thing, but I had a seizure a couple of months ago with the complex. And we dialed 911 and had EMS coming in. What happened? Campus Police got there first, and Campus Police actually intercepted EMS and redirected them to the wrong place. We told them exactly where to go. We had somebody waiting at the gate to guide them in, but they were intercepted. It happens sometimes. So we sat down and did a review after the fact, and we sat down with Campus Police and said, first of all, y'all do a great job. We really appreciate y'all, but this is what happened. And can you sit down with your staff and talk about that again and make sure we're all on the same page and communicating? Of course, we had a good outcome. What if something had gone south with this? And that 2 or 3 minute delay in them getting there because they were redirected to the wrong place could have made a critical difference. So again, taking a critical look at it, document it, and how can we get better? Documenting our responses, our plan. You know, if we go over C-spine, do we do a good job of documenting that? If we talked about exertional heat notes, did we document that? And then if we have a change in our plan, how do we modify it? Why did we do that? This is a pocket emergency card that I've used for years and years. It's a 3x5 card we laminate. On one side, I've got my emergency action plan for football. On the other side, per the medical conditions. Who are my sickle cell athletes? Who has asthma? Who has diabetes? Who has a seizure disorder? Who has instant concussion? Who's on certain medications, like, for example, psychotropic medications are more and more common now. In the South, we have a lot of heat, and they affect our thermoregulatory system, which affects heat dissipation. So I need to know what medicines are on. Again, I like to think I'm smart enough to remember all this stuff, but I'm getting old now. My memory's fading. I got 135 football players, and I don't want to forget about that. So we review this on a regular basis, make sure it's updated, and I keep this in my pocket. Now, somebody asked me the other day about, would this be a potential HIPAA or FERPA violation if you lost it? Absolutely. So I need to make sure it's secure. Now, the other thing you could do, which we've also done as well, everybody has smartphones now. So we just simply put a file attachment on our app. So if I go to the front page of my phone, tap that file attachment, I've got this right there. I've got my behavioral medicine emergency plan, my crisis management plan, all my individual institutional venue plans right there on my phone. It's secure with a password, so I can protect it that way as well. But again, making sure that I've got this information so I can need it in a timely manner. Catastrophic guideline, what if something bad happens? What if that divine deal situation happens? I'm at the ED now, and I know I've got a lot of people to call. I got some steps to go through. Again, these don't happen with great frequency. I want to make sure I've got a plan so I don't miss any steps. So a simple thing, if it happens after hours, we can't assume anything because we know what happens. If I get a call at 3 in the morning, which is rarely when most emergencies happen after hours, make sure my team physician is aware of it. I can't assume anything. If it's especially, make sure my specialty physician knows about it. My athletic director knows about it. I guarantee my president wants to know about it. Sports information, whether we're going to discuss it or not, sports information needs to be a heads up, because if they get a call from the media, they won't want to get caught off guard. Another simple thing, who's in charge between campus and athletics? This Divine Gills thing was on TV, and there was a lot of media recognition about it, and people want to know answers. So they're going to call our sports information department. They may call the university spokesman. Who's going to be in charge there? Somebody has to be the point person and say, if we're going to make a statement, who's going to make it? What's it going to say? So make it communicate these things. Again, ironically, this was the one game in Devon's career his mother and dad did not come to because they had something with one of their younger children. So they're down in Baton Rouge watching on TV when their son has a spine injury. And now they're trying to figure out how to get up there. So we have to set an emergency flight. I got my travel agent's number on there. I've got Air Med on there, MedJet. Any numbers I need, I want to have on there. It's just a simple checklist, step by step by step. Did I do this? Did I notify this? Compliance. Again, making sure we're following the rules. His family literally came up there without packing a toothbrush. We had to get a police car to get them there and have the plane waiting for them on the last flight out of Baton Rouge. So they came with nothing. Provide them with clothes, toiletries, hotel, meals. We can do that with NCA, but we have to follow compliance rules to make sure it's legal. Have I gone through that step? Which is a simple step-by-step guideline to make sure I'm not missing anything. Again, we think about taking care of our athletes, think about taking care of the family, other people, the teammates. How about ourselves? Something called curriculum and stress management. This is something typically in EMS that I picked up a number of years ago when I went through EMS training. But if you think about it, EMS may be one of the most stressful occupations you have because all they deal every day is with emergencies and people who are upset and traumatic scenes. And if you've been around EMS long, you don't see a lot of older EMS people. You don't see a lot of older paramedics because a lot of times they have a transition, can't stay in that career very long. So how can we take care of ourselves? If we don't take care of ourselves, we have a hard time taking care of other people. And I tell everybody, it's like an analogy of a sponge. If I took this bottle of water right now and poured it on the countertop, I get a big pool of water. So I can get a sponge and try to clean it up. And if I push it around, if I don't wring that sponge out, I'm just pushing the water around. I'm not changing anything. But if I soak up some, wring it out. Soak up some, wring it out, I'm helping the situation. That's the exact same we want to do in curriculum and stress management. How are my staff doing? We had a situation a few years ago. We had sort of a unique situation. I had a 19-year-old student athlete trainer with me named Kai Summit. He's actually now the head trainer for the Miami MLS team. But he was actually involved in a situation right here with a catastrophic baseball injury. And about 2 months later, we had a cardiac arrest with the SEC coach that I managed, and he was right there by my side. And you think about it, a 19-year-old young man who's not certified, he's still an undergraduate student who dealt with 2 life and death things. Now, fortunately, he handled those really well. But on both of those, we did a curriculum stress debriefing. How's he managing those? Sit down with a counselor. Is he doing okay with that? We had a cardiac arrest a few years ago with an employee, and 2 of my grad assistants managed that. They'd both been there for maybe a month at Georgia, right out of the school, just certified. One of them did really well with that. One of them really struggled with it, had nightmares, woke up at night, panic attacks. Even though the person survived, they did a great job, that was a traumatic event for her. She never dealt with it of that nature before. And even though she did really well at the time, it was the aftermath that got her. So making sure that we do a good job with this. So as a case example with the Devon Gills case, with this case, we sat down within the first 24 hours in a room with everybody involved. The athlete trainers, the physicians, the paramedics, student athlete trainers talked about it. What went good? What went bad? What can we have done differently? And more importantly, how are you handling this? How did you sleep last night? Are you doing okay? And making sure we follow up on that. Because again, as healthcare professionals, we can only take care of people effectively if we take care of ourselves first, and don't forget that. So summary. The good news is, again, and if your students here, my purpose of this wasn't to scare away from profession. But again, bad things are going to happen sometimes. They don't happen with great frequency. When we do, we got to be prepared. So the difference can make a difference between life or death or permanent disability if we make those right decisions. And that decision and their survival is based upon what we practice. So we won't have good ownership. It's not just a sports medicine issue. It's an athletic association issue. It's an institutional issue. Everybody's involved. And the most important thing is to rehearse and plan and go over, practice and practice and practice. Practice makes perfect. With that, any questions? Sir.
One from the webinar. So you indicated that if you transport someone from a venue, or you have EMS transport someone from a venue, you rotate sort of one of the spectator buses to take that place. Do you communicate with like all 7 of the crews during the medical timeout before the event, or is that something that you only do with the crew that you expect to take care of your athletes, or how does that work?
That's a great question. The question is with your medical timeout, do you communicate with your spectator people as well? Now, you can do different ways. The way we do it is when we have our medical timeout, we have event management there. So I have my AD for event management. The paramedic crew I have is only for on-the-field play. So we talk about what specifically would happen there. My paramedic is on the radio with the rest of the crew. And the event manager, we actually have an event manager's operations center up top that has fire rescue, police, everything in there. Meteorologists for the weather. So they have like a command center. So we had something like that. The radio call would go up and they would disseminate out to everybody else. But again, just making sure that one hand knows the other one's doing. That's a great question. I will talk about this thing right here. How many people here are EMS? One thing they always talk about EMS is scene safety. You know, the first thing you want to do when you go to scene before you start your primary secondary survey is to scene safe. You know, if it's a motor vehicle accident, I go out there, I want to make sure my back is covered to make sure I'm not hit by an oncoming car. If it's a track and field injury and they're throwing the javelin, I want to go out in the middle of the field, make sure the scene is safe. Other thing we want to ensure in athletics is the scene controlled. And this is a great example here. This is a SEC injury with the C-spine, but the entire team is on the field. And y'all saw a couple years ago with the Central Florida quarterback who dislocated his knee on the sideline. Not only was the entire Central Florida team, the South Florida team that came across, so you literally had 300 people there, and they're trying to work in the middle. You can't get the ambulance in, you can't get the cart in. It's hard to hear because you got so much concern, and people are well-meaning, but they're actually in the way. So we also want to think about scene control. And this is another thing you can think about in your medical timeout. We actually involve the officials there. So before the game, I meet with officials and say, hey, Mr. Official, can you help me out here? If we have an injury, can you keep the guys in the box? Keep them back to give us space. And they do a good job with that. Another thing, we use our team chaplain. We have a Thomas Sells, our FCA chaplain, does a great job, and our guys love him. But I sit down with him before the game, and you're thinking, why do you talk to your chaplain before the game? Thomas can be a big help with the Devon Gill saying it was traumatic because it happened right in front of our sideline, and our guys heard him tell me, I can't feel anything. So it goes through, he's broken his neck, and they're upset. You know, the guy he hit is really upset. But Thomas did a great job of getting over in the huddle and saying a prayer with them. And it actually really helped diffuse the moment, control that situation. But what it also did is keep our area clear. So again, thinking about before the game, another thing about that situation is living on the sidelines. If I'm right here, sidelines was Sally right there. And if this was a non-conference game, we dressed at 135 guys. And you know how congested the sideline is. And I didn't realize till after when I looked back at the video, my student trainers did a great job. They stood side by side and made a line and backed everybody up. It actually made a shield between us and the field. So did a great job with that. But scene control comes from practice and communication. So don't forget about scene safety, but also scene control. Yes, sir.
Do you have any advice for
smaller school in a very rural setting where, EMS services may not be readily available on Friday nights, or in general where a response time may be, longer than 10 or 15 minutes at times? Do you have any advice for somebody that might have to deal with a situation like that?
Yeah, the question is, if you're in a small rural high school area and you don't have the same capabilities and you need more help, what are your resources? One of the first ones is your coaches. Your coaches can be a resource, and are they trained medical providers? No. But can we make them first responders? Absolutely. So this is something we've been doing in Georgia for 25 years. All of our coaches are required to be trained in first aid CPR. So we sit down with them at the first of the year. I usually do it again in football in July and get it fresh in mind. So Coach Tucker's used that. He did it for 3 times. But we sit down with them for about 3 hours, and we go over CPR, AD usage. We talk about emergency action plan, give them a copy of it. We do not a first aid certification, but a first aid review, give them scenarios. And the nice thing about doing it then is a teaching platform. I can remind them, hey, coach, this is your guy who has asthma. This is your guy who has sickle cell. You got to watch them a little more closely. But again, if I can train them, and again, I'm not expecting them to be a medical person, but if you think about it, can the coach make a 911 call? Absolutely. Can they retrieve the emergency kit? Absolutely. Can they go and unlock the gate and make sure they direct the ambulance in? There's a lot of things we can do with them if we do it effectively. So again, on the front end, what resources can I make? So if I can train my 8-person football coaching staff in high school, that's a force multiplier. And again, I may still be the only true medical person there, but I've got some people that have been trained to do some assistance that can help me out to free my hands.
Ron, can you speak to the benefit at the other end of the spectrum from where Brad just talked? When you travel, Glenn goes with you, correct?
Yes.
And what value is there in having that individual with you?
I've been
explain to them who Glenn is.
Yeah, Glenn here's our paramedic, and Glenn's been with me for 25 years. I've been blessed. I've had the same sideline crew for the most part for 25 years. So we're paramedics, so they know what we do and we know what they do. But I started a number of years ago taking Glenn. And it's like anything else, athlete trainers communicate well with each other. Physicians communicate well with the other. Paramedics do as well. So a lot of times when I go on the road, and it may be an EMS crew I've never met, if Glenn comes up and says, hey, I'm Glenn Henry, I'm the paramedic there, it automatically establishes some trust. So they know he knows what he's talking about. And the same thing helps us because all my staff are EMTs. So they know that at least we know a little bit what they do from a terminology standpoint, from an IV hydration standpoint. And again, we're not a big IV school. I know there's some people that drop lines on everybody. We don't do that. Hopefully we don't IV anybody. But the reality is most of my physicians, they'll be the first to tell you they don't start IVs. Dr. Restek, my TED team physician, is the best guy I've ever worked with. And he runs a sports medicine clinic. But he doesn't start IVs in the clinic as nurses do. And the same way from a trauma standpoint, I've got great physicians, but if we've got to drop an emergency airway, the last time our orthopedic took a laryngoscope and dropped an ET tube was in residency. And that was 25 years ago. So Glenn's my rapid sequence intubation guy. So again, if I have an emergency, I've got somebody who's trained in that. And we just made a decision a few years ago. I have my physician I carry Glenn, and he makes a big, big difference with our program.
So if you're working in a high school environment that's maybe in a large school district, how do you go about approaching and gathering stakeholders to do some of the training, sort of to get them on the team at the beginning so that they can be a regular member of your training and sort of team that you rely upon?
Okay, the question is, if you're a high school trainer, how do you get more stakeholders? How do you get people involved? Again, college is different because you've got a really controlled medical environment. I have the same team physicians can see everybody, where if you're in high school, you may have 25 physicians because everybody is somebody's child and they may have a pediatrician or somebody they know. I found the biggest thing is people want to get involved if you simply ask. They may have intentions, but they never get taken because nobody asked them. So, I did work on the high school level for a couple of years. One thing we always do is at the Booster Club with the parents, we talk about what our needs are and try to find out if I have anybody maybe who's a physician as a parent. Do they want to get involved? I have 2 sons right now that play high school sports, and one of my ED physicians' son plays on their high school team. So he volunteered to be their team physician. So they got a great situation now. They have a trained trauma physicians on the sideline for every game. One of the other parents is actually one of my former athletic trainers, is a PA now. So they have a PA-ATC out there every time. We got them with the athletic trainer, and they work together really well. What you don't want to do is have that parent show up on the sideline in the middle of the game, say, I'm a physician, I want to take a look at him. Hopefully it's been done on the front end. But again, I think the more communication you can do and make people feel welcome. But you know, if you can find a role to get them involved in and do it the right way, it can definitely be beneficial. Any other mercy? Yes.
Sorry. Have you had any legal issues or discussed with the university council or other lawyers about the risks of engaging coaches or other non-trained medical professionals in things like spine boarding or other aspects of the action?
That's a great question. From a legal standpoint, what can coaches do and not do? And how can we avoid legal issues? I think we've got to be really smart about the level of involvement they have. Now, again, from a coach's standpoint, with our coaches, again, we train them in first aid, CPR, AD usage. We talk about first aid. We make it very clear that they know they're not a first responder. They're not going to look at something and say, hey, there needs to be stitched, go to the emergency room. They're going to refer them to medical. But again, from my standpoint, personally, I don't feel comfortable in coaches C-spawning. You know, I think that's beyond their level of training. Do I have a problem with calling 911, going to retrieve the emergency gear, helping control the scene? I think there's some things we can do, but I think you want to clearly define and get legal involved in that. What can they do? What do we want to steer them away from? Yes.
What having coaches help you like ball roll or create a small little school again, there's not a ton of people there. You're working at the head.
Mm-hmm.
That's
a great question again. Would I let a coach help me log roll? And I learned a long time ago, Jim Andrews was one of the guys that got me into sports medicine. And Dr. Andrews had a saying, there's no such thing as always and never. There's no such thing as always and never. When you say that, that's when you get in trouble. So I wouldn't say I would never let a coach help me do that. My gut inclination, this more me personally, I would like to keep that to the medical part. Now, at the same point, if I've got somebody in respiratory arrest or cardiac arrest and they're in a prone position and the only person there I've got is a coach, that's life-threatening. And we've got to do what we've got to do. And I may train them real quickly to get them over so I can resuscitate. But in most situations, if we have the time to deal with, I want to wait for more trained persons to come in, because from a legal liability medical standpoint, you're going to increase your risk of exposure if it can be shown that it wasn't truly emergency at the time and you had somebody do something they weren't trained to do. Now with that, we had a couple of spine questions, so why don't we roll to the next area and talk about the spine. And what we're going to talk about today is some newer things, and this has really been a hot topic, probably about the last 4.5 years with the NATA and the profession, what to do with the spine injured athlete. And what we're going to do today is actually talk about some of the things that are coming out of the NATA right now and some inter-association things, and hope you get some information. I don't have any financial disclosure with this. But the objective with this is talk about national EMS standards, and they have changed dramatically in the last 5 years. And it's changed some healthcare options. And, you know, a lot of times in sports, we like to have protocols. You know, if this happens, you do this. If this happens, we're going to do this. And this is a great example of you really can't, because there's so many variations in equipment, in training, in state statutes. For example, there's some states right now in the U.S. that no longer carry spine boards. They no longer carry spine boards. So my protocol is I'm going to spine board this athlete. I'm in trouble when the ambulance comes unless I have my own. So there's been a lot of changes. We're going to sort of talk about those, why they developed from that perspective, and how we can address this. This actually really happened before this. About 5 years ago, the NATA started a group called the Inter-Association Task Force on Pre-Hospital Care of the Spine Injury Athlete. And what we did, we reached out to 14 different professional organizations, the National EMS Association, trauma physicians, AOSSM, AMSSM, and so forth. So we had a big group of people from 14 organizations, and our goal was to come out with an inter-association document, just like we have many other documents. But what we found after about 2 years of work, it wasn't possible because there were so many variations from state to state, and there were so many people who were adamant about certain ideas. You know, we had one group that wanted to adamantly say you have to spine board everybody with potential spine injury. And unfortunately, that's contrary to the national EMS protocols right now. And then you get into small things about may versus should, and we got very close to the document, probably about 99% of it done. We never could finalize it because we never could agree. So we tried to backtrack and say, let's go a different way. Because the reality is, looking back, it probably was unrealistic to think I'm gonna get 14 people to agree on anything, particularly 14 big organizational bodies. So we said, let's look at it a little different way from the concussion standpoint. If you remember the concussion papers, they're not consensus papers from organizations, they're from subject matter experts. So when they put together the concussion guidelines in Vienna and Prague and so forth, they didn't ask associations to come in and be involved right then. Now, some of them came after the fact, endorsed it, but what they said, let's get the top subject matter experts in country concussion and come up with some consensus on our own and write a paper and get everybody to come on board. So we said, let's do the same thing with this. So we actually got a group of 25 healthcare providers from a variety of different settings, from medicine. We had ED physicians, we had orthopedic physicians, neurosurgeons, trauma surgeons, sports medicine physicians, had athlete trainers. And one thing we really tried to do with this too is make sure we represented. We had high school athlete trainers. We had small college, large college, professional sports athlete trainers, because again, we've already seen in these questions, there's a big difference what we're going to do in a small rural high school versus a metropolitan high school versus a college or professional team. And that's the reality of it. There's different resources there. So we brought in EMS, paramedics, brought in researchers and said, let's get all the subject matter experts together in this room and come out with something. The next thing we said, we want to make it as evidence-based as possible. So we actually contracted through the University of Washington. They have a nationally recognized research institute. And we did a literature review and actually looked over the last 20 years at over 1,500 articles related to C-spine management. And then we did a modified Delphi study. And this was interesting to me because going into it, I really didn't know what a Delphi study was. But Delphi study is trying to make it evidence-based. So everything is anonymous. So we had this group of 25 people, and this we communicated by email. And we came out with a series of questions. You know, for example, a simple one. If you have a spine injury, do you take the helmet off or leave it on? And, you know, who agrees on that? And you can't go until you have at least 75% of the people agree on that. And again, what happens with this is now everybody has a vote. It's not the loudest person in the room. Because you can imagine if you've been in contentious places before and you've got 14 different organizations, sometimes the loudest person wins, and they may not be the right decision. So we went through it step by step by step with the Delphi process, refined questions, and then once we had those done, we actually had a face-to-face meeting. So we had a summit meeting at the Shepherd Spine Center in Atlanta, Georgia, right about a year ago in March 2019, and we had everybody there. And again, we went through each question, and then we developed recommendations and conclusions. And again, each one, we couldn't succeed unless 75% of the room passed it. And we moved on to the next one. If we couldn't reach a consensus, that was tabled and we put it away. So the goal was to come out and produce a paper, evidence-based. So we actually came out with 20 conclusions and 50 recommendations that everybody in the room agreed upon. And that's going to be published right now. We actually just found out this week that we've been accepted for publication with both of the papers. So the first evidence-based paper is going to be published concurrently in 4 different journals. Because one of the issues we have right now is there's a lot of difference in terminology and the way we exchange information. For example, if y'all know Mary Beth Wardysky at the University of Florida has done some groundbreaking research in the lift and slide with cadaver dissections. And we know from an evidence-based standpoint, that's a great maneuver. But if I talk to paramedics about lift and slide, they've never heard of it. And how many EMS instructors, it's not in the textbooks right now. And the reason being, it takes 8 people to do it, and there's 2 people in an ambulance. So I said, well, why do we need to learn that? It's not realistic. So, you know, making sure we're communicating. You know, physicians have never really had formal training how to remove helmet and shoulder pads. So we said, let's come out with a document that could train everybody and go across lines. So if we just publish this JAT, it's really going to get out there. So we made a decision to concurrently publish this in 4 different journals. It's going to go in the Journal of Athletic Training, so it'll hit all the athletic trainers. It's going to go in the Journal of Emergency Medical Services, or GEMS, so it'll hit every paramedic and EMT in the country. It's going to go in Annals of Emergency Medicine, so it'll hit trauma physicians and ED physicians. It's going to clinics of sports medicine, we'll get our team physicians. So the whole idea is to post concurrently and try to throw that net out as many people as we can. Then we also wrote a best practice paper. Now the evidence-based, again, is evidence-based on the collusion recommendations. The best practice, the reality is a lot of stuff we do right now in sports medicine, whether we're talking about modalities or rehab techniques or emergency medicine, we don't truly have a lot of evidence on right now. There's not a lot of evidence on, for example, cervical collars. We used them for years, but there's not a lot of evidence behind it. The same thing with spine boards. We used it for a number of years with relatively good outcomes. There's not a lot of research behind it. So we wrote a best practice paper, and that's sort of like a how-to manual, step by step of different techniques. And it's been accepted as well. And then we have an educational video that we actually filmed at the University of Washington. And what we actually did was create scenarios and did it on the field with a production company. We did it on the field, and we transported the patient in ambulance, took them to the ED, showed them in there, talking about collaborative working together with the trainer and the paramedic and physicians on how to remove equipment. So the whole idea of this is to try to get everyone on the same page. So where this stands right now is the papers have been accepted for publication. They'll be put out sometime before June. The video is ready to come out right now as well as final editing. And then in June at NATA, we're going to release all this information. It'll come out. So, and then the idea is to make it accessible to everybody. So for example, this video is going to be free of charge. And it's going to be available on any website. So if the American College of Sports Medicine wants to put on their website, they can. AOMSSM, NATA, anybody. And again, we're speaking common language. So if I'm an EMT instructor teaching paramedics, I can show this to my class. If Sally and Tracy are teaching this to their athletic training curriculum at Michigan State, they show it their class. If I'm a physician working in a trauma center and I want to train my nurses and doctors on how to remove equipment, I can show it to them on ambulance service. So again, we've got the same terminology endorsed by multiple people, and we're giving a common message. So we're really excited about this. And I'm not going to share everything about this today, but I'm going to talk about some concepts on how we developed this. But this is all embargo right now, but it's going to be released officially on June 18th at NATA in Atlanta. So we have a spine injury. And again, pre-hospital care is evolving, but our goal has not changed. I've got a catastrophic injury right here. I've got a young man with a C5, C6 core transection. How can we safely package him, get in the hospital without causing any further damage? Because the first rule of medicine is cause no further harm. A few years ago, there were back in 2015, there were some sweeping changes in EMS. And this came out of the American College of Emergency Physicians. And the reality is it was correct. We've been spine boarding too many people for too long. I've been an EMT for over 30 years. And protocol was if somebody had spine pain, you put them on spine board. You may pull up a car accident and the patient is talking to the policeman standing outside the car. And he asks him if they have spine pain. Yeah, my neck's sore. The protocol is to put them on spine boards. So you literally put a spine board behind them standing up, lower them down, strap them. Now, was that necessary? Probably not, but that was the protocol. So for too many years, we probably spine board too many people. And spine boarding can be very effective. Has anybody ever been on a spine board before? They're uncomfortable. Your bony prominences, your head, your scapula, your PSIS, your heels, there's a lot of pressure. You can cause pressure sores. If they're put down too tight with straps, you can cause respiratory issues. You can actually cause some problems with the spine board. Now, does that happen very commonly with athletics? Probably not, but potential's there. So the first thing they did is they differentiated between spinal mobilization and the new term, spinal motion restriction. Spinal mobilization always implied putting them on a rigid device. Spinal motion restriction simply means that we're restricting them. And the reality is immobilization is not a true term. There's no way I can have somebody with an unstable C-spine and truly immobilize them. You may want to think that, but in reality, we really can't. So how can more importantly restrict spinal movement? But we just say that it still is required. You know, it may not be required for every patient, but if I've got somebody in a high-speed collision or an athletic event, there may still be a medical need for that. So we're not throwing it out with the bathwater. So This is what happened. They actually came out with 2 criteria. When is it not necessary? If I have somebody with normal level of consciousness and I can rule out, I can do an evaluation on them, I can talk to them and rule out C-spine trauma, there's no need to mobilize them. If they don't have any spontaneous or anatomic abnormality, if their neurologic exam is normal, there's no reason to mobilize that person. But at the same point, if I have somebody with a trauma mechanism and they have all levels of consciousness, if I can't talk to them to communicate, I can't rule it out. So I have to assume they have a spine injury and package them accordingly. If they have spinal pain or tenderness, if they have a neurological complaint, if they have a deformity or high injury mechanism, those are still accepted criteria to immobilize somebody, or as we said now, spinal motion restrictions. And what are those? Now, again, from a national standpoint, there's a wide variation in treatment. Now, we have state EMS protocols, and you may also have local protocols. So like in Georgia, we have 10 EMS districts, and we have some state guidelines. We also have district guidelines. So District 3, maybe District 10, is based upon their chief medical officer in EMS in that area. So really important for me to know my local protocol. I may say, for example, I'm going to take you off from the field of play. If the paramedics protocol is to leave it on, that's not going to work. And we're going to lead to conflicts on the field, and that's not what we want to have. So again, we want to find out what our protocols are. What emergency equipment is available? Like we said, I know of 3 states right now, the U.S. no longer carry spine boards. Some states don't carry scoop stretchers. We did that video at the University of Washington this summer. And we went out there, I had the checklist, and we needed a scoop stretcher. We had a hard time finding it because they don't carry them on ambulance in the state of Washington. What is available? Key point, who's personnel on site? Now, again, with that situation in Devon Gales, I had 3 paramedics on the field. I had my staff on the field. I had my physician on the field, my student trainers, and we had over 20 medical professionals. So it was very easy for us to take care of that. In a high school situation, that may not be the case. In a college practice, that may not be the case. We had a baseball injury in practice a few years ago where I had my surf athletic trainer, and he was the only one there with 1 student. So we're not going to try to move them, immobilize a person. We're going to maintain them in a safe situation till the cavalry comes with EMS. So again, it depends on my personnel site. Do I have a physician on site? Do I have an EMS on site? Most importantly, what's the training and expertise of that personnel? And that was something we were talking this morning about Margot Patukian. Margot was on our committee and a really, really sharp physician. And she raised a point. She said, hey, Ron, you know, if y'all had that situation, I'd trust you to move the equipment. But if I had a brand new grad assistant at Princeton who's been certified for 6 months, I probably wouldn't because of the level of training. So that's got to play in as well. Position of the athlete, what they're on their side, on their stomach, on their back. A great example, they had a bizarre situation at Auburn, Ole Miss a couple of years ago. The Auburn team physician is a great friend of mine. He called me up after the game, and they were playing Ole Miss on the road. And the Ole Miss running back had the ball, and he goes through, and he's trying to avoid a tackle, and they had a D and a safety come in from opposite directions, and he went low, and the 2 tacklers collided helmet to helmet. Both went down. One had a concussion with loss of consciousness. One had a cervical spine injury. The athlete with the spine injury was laying prone on top of the running back's legs. So how do you deal with that? They had to keep the running back still, say, son, don't move. The guy on top of you's got a bad injury. You don't move, you stay still. They had to take the board and balance it on his upper body and had 2 people to keep it from going like a seesaw, and the log on there. Now, how often does that happen? Well, that's a great scenario. That's why we do scenario-based training. But again, the position of athletes is the issue. Space restrictions, scene control, safety control. So we got to factor all these things in. And again, like Dr. Andrews said, there's no such thing in always and never. We do the individual situation and how do I manage it from there. Background, again, we've got a variety of people involved. I've got the spine injury on the field. I've got my staff. I've got 2 visiting staff that I don't know I just met before. I've got my paramedics who I do know. I've got my physicians. I've got an orthopedic surgeon. I've got a neurosurgeon. I've got a vascular surgeon. I've got a PA athletic trainer and a primary care physician. All different degrees of expertise. How do we make them work together? Again, we get a protocol and we practice. Again, what we want to do in this situation is know every technique. I want to know how to remove equipment. That doesn't mean I'm going to move it every time, but I want to know how to do it. My oldest brother was a police officer for many years. He never fired his gun in the line of duty, but that didn't mean he didn't practice all the time. When something happens, I want to know how to use that technique, and I want to practice different ones. So again, based on situation, I can pick the correct technique to use. We talked about emergency action plan. The one thing about this, really encouraging, that's going to be one of the developments out of this, is a recommendation to develop a C-spine protocol. You may remember a few years ago, the NCAA came out with a recommendation to make a written concussion plan. And I heard a lot of angst about that. Oh, that's just one more thing I got to write. But that was actually a really good thing because it forced us to put everybody on the same page. And with the medical legal implications now, it's the best thing we ever did because I can document that I have a return to academic plan, I have a return to athletic plan. I can document how many times my physician is going to see them, what testing we're going to do, and everybody's on the same page. Because in Georgia, I've got 24 athlete trainers. If my swimming trainer is treating somebody different than my basketball, my football, my track, I've got a problem. So if I got a protocol, and again, protocols, you want to write the right way. I can't make them so black and white they limit us. But again, I want to make sure they're guidelines and make sure we're on the same page. So if we write a C-spine protocol that my neurosurgeon signed off on, and my orthopedic spine specialist signed off on, and my primary care team physician, and Glenn Hamer, my EMS director, and myself, if we're all on the same page, now we know we're not getting the problem. And we sat down with our regional EMS director and make sure our protocol fits there so we're not getting the confrontation on the field. So what would really encourage you to sit down with your staff and come up with a C-spine protocol that works for you. And again, Margot's a great example. I love Margot, worked for a number of years. Her C-spine protocol at Princeton is dramatically different than mine, but it works for them and mine works for me. And there's not a right or wrong way. It's like they say, there's more than one way to skin a cat. So find out what works best for your situation and your scenario. And that's what we're really trying to emphasize is care concepts. Medical timeout, can't emphasize that enough. Teamwork, we got to work together. Assessment, the first thing, we can't treat if we don't recognize it. So the first thing is my scene size up. Is my scene safe? Is my scene in control? What did I see? Again, if I'm on the sideline and I saw somebody with a violent mechanism of injury with axial load and they go down motionless, as I'm going out there, I'm already thinking possible spine injury. First guy out there is going to get the head and mobilize that, keep it still. You know, are they moving around? Are they yelling and screaming? It may be bad, but if they're yelling, my leg, you know, I may feel bad about their leg, but what I know, they're conscious, they're alert, and at least primary circulation, airway, breathing are intact. And I knew that before I even ran into them because they're yelling my leg. So what's my size up? What I see as I'm going out there. Our primary survey should be done in less than a minute. ABC, LOC. I'm not going to try to get a lot of hard numbers. I just want to see, do they have an airway? Is it open? Is it patent? Are they breathing? I'm not getting numbers right now, but are they breathing, yes or no? Is it slow or fast? Is it labored or unlabored? Circulation, what's their circulation status? And then based upon that, I'm going to make a transport decision right there. If they have impaired LOC, ABC, we know we're going to transport. Well, we're going to go into the secondary survey if EMS is not there. Do a detailed secondary assessment, head-to-toe survey, more specific, getting some hard numbers now, my vital signs, my sample history. Okay, what's their signs and symptoms? What are their allergies? Are they allergic to anything? Are they on any medication right now? What's their pertinent past medical history? Last oral intake, events preceding. So step by step by step, but the big thing in emergency medicine, we can't treat what we don't recognize. Question of the day, and we still haven't answered exactly, but when should protective equipment be removed? Now, I think we'll all agree it has to be removed at some time. I've never seen somebody in the hospital 3 days later, they're still in their helmet and shoulder pads. It's got to come off. Where do we take it? Is there a right or wrong answer? There's not. There may be times to take it off on site. There may be times to take it off in the ED. So again, we've got to make sure that it's care concepts. Everybody knows how, and then we can make those decisions. Now, the one thing, and I know we talked about there's no such thing as always and never, but there's one relative that always factors in, airway access. Before I shut that door of the ambulance and transport that athlete, I want to make sure I have access to their airway. So that means one of two things happens. The face mask comes off or the helmet comes off. I don't care what the respiratory status is at the time. Because what if they're just like that cheerleader, where they fell at that podium and they're doing okay, but then 15 minutes later, they had a blown pupil, projectile vomit, unresponsive. They changed, they downgraded. That can happen with the C-spine injury as well. Maybe they've got an upper level 1 and all of a sudden it affects their phrenic nerve and they stop breathing. They're in the back of the ambulance. And now you've got a paramedic back there by themselves with the face mask on. How does he get it off? So before we transport, making sure we have access to airway. And again, that can be the face mask off or the helmet off. Now, there's some advantages of taking the protective equipment off. It facilitates the evaluation. The ED physician can cut the chase. We can do diagnostic testing. Because the reality is we really can't do a lot of diagnostic testing with the gear on. Now, I know in the past there's been some studies where you shoot cross-table x-rays, look at C-spine to make sure anatomically they're okay. But even with the pads and helmets, it's very hard to visualize that. So if the equipment's off, it does facilitate the evaluation and diagnostic testing. But the flip side is safe equipment removal takes 3 to 4 trained, experienced people. And that may not happen all the time. And again, in a college or professional setting, absolutely. In a high school setting, you may have 1 athletic trainer. And just like the question raised before, is it appropriate to get 2 coaches and try to coach them on the way? They might do a good job, they might not. But what if something adverse happened? And then you've got to look at the medical legal ramifications. So I think one of the decisions we have to make, we're thinking about when equipment should come off and where it should come off, is where to have the most people. Now, and again, in a college situation, to me, it makes sense. In my situation, I've got more people on site because I've been there before. I've been in an ambulance and with a spine injury, and I go there by myself, and I walk in, the physician comes in and says, "Hey, Ron, get that gear off. I'll come take a look at him." And now I've got 2 nurses and an OR tech that have no idea what a helmet is. I've literally seen somebody try to cut a helmet off with a cast saw before. Now think about that. How would you like to be inside a helmet with somebody having a cast saw, that thing vibrating, shaking? That's, talk about calmness contagious. That's not going to instill calmness in me if I'm inside the helmet. So we've got to be trained and experienced in how to do this. We got to be familiar with equipment. And boy, there's some variations of equipment. Think about helmets. Right now, there's probably 4 main manufacturers of helmets. We've got Rodell and Schutt, the whole guard. We've got Zenith. We've got Vice is the new one. Think a simple thing about cheek pads. Vice is screwed in. You have to have an electric screwdriver to take them off. Rodell are Velcroed in. And it's hard to take that Velcro off when they're inside somebody's head. There's differences in face mask hardware. How are we going to get these off? Shoulder pads, exact same way. There's different shoulder pads now. It used to be we cut the strings, but now we get the solid breastplate. Again, they protect sternal injuries, but they're very, very hard to cut. And the reality is we have some shoulder pads and materials that are impossible to cut. How do we get them off? We got to be familiar with techniques. Again, Jeff was familiar with this when Drew and I were evaluating Devon Gales. Now, Devon is not a big kid. He's about 160 pounds. But when we started looking at him, he had a collar on. He had shoulder pads on. He had spider pads on, a back plate and rib pads. He had about 10 extra pounds of pads, had a lot of pads related to him. But again, I want to make sure I know how to get all that stuff off because we did a lift and slide technique. And what I don't want to do is get him up in the air levitating. He realized I forgot to get his back plate off. Now, how am I going to do that when he's in the air? So making sure we're familiar with the equipment, and that's going to dictate how we take it off. Helmet removal. Again, whether we take off in the field of play or in the ED, we have to know how to take it off. And there's some specific techniques. And this changed a lot with technology as well. Now, I remember in the old days, you talked about helmet technique. We also talked about deflating the bladder. And I was speaking with the NFL group the other day, and we went to the ED and we're talking about it. The protocol was their physician to deflate the bladder. Well, a lot of our helmets now don't have bladders anymore. So this physician, he could look around all day with a little needle, but there's nowhere to stick it in. So again, know your technology. The same thing about cheek pads. We also talk about taking the cheek pads off. With the new ear channels now, you really don't have to do that because it comes off much easier. And quite honestly, we may have less movement, not worrying about fiddling with the cheek pads. Again, with a Little League kid, our helmets right now at college and professional have removable face masks. Some of the Little League helmets, like the Rawlings that's still out there, it's bolted to there. I can't remove it. So I'm going to have to take the helmet off with that. Does the helmet fit? You know, a lot of times I think in professional and college, we can assume they do. High school, we're probably making an incorrect assumption if we think all the helmets fit. Because I know how, when my son plays football, how they fit his helmet. Here, son, put it on. You look like an XL, you look like an large, put it on, see how it fits. They're not professionally fit. If I have somebody, and we had the situation a few years ago at Georgia, we have this deal where the YMCA comes and plays games on our field before our games, which is really cool. My son did this at 8 years old. He's played Between the Hedges at Georgia. But I'm out there in the training room one day taping, and they call me and say, Ron, you got an injury on the field. And we had a 10-year-old go out there complaining of spine pain. And I looked at him and evaluated him. I could literally take 3 fingers and put them between his cheek pads, his helmet. His helmet's probably 2 sizes too big. Now, if I immobilized him and strapped his helmet to the board, is that going to control his head movement? Absolutely not. So we got to be familiar with helmets and know how to take them off. Helmets are going to take a minimum of 2 rescuers. So step by step, take it off. The first thing we have to do is expose the chest, because the obvious one to take the helmet off is the one at the head. So we're going to have to transfer C-spine from the one at the head holding it to the rescuer on the side. How do we do that? The first thing, I want to cut the jersey. I want to take what they call a T-cut. I want to take my scissors and I want to cut sleeve to sleeve across here. And then I want the top of the T, I want to take my scissors and go with the neck and cut down. And I want to be specific. I don't want to cut up. I want to cut down, so I'm keeping the blades away from their neck. So T-cut with the jersey. Now I'm going to cut through the front of the pads to expose that. So now I can come in and I can take C-spine from here. Now Liz is doing what we call an anterior-posterior technique. In the past, we used to use more of a medial lateral technique. We come on each side of their head. Honestly, that was the reason we talked about taking the cheek pads off, because you had to have space for your fingers to come in. This is a new technique now that we're advocating for a couple of reasons. One, you don't have to worry about the cheek pads with the side of them, but I can control the rotation better because I have a hand around their chin. Her backhand is right around the occiput. So I'm actually making a cup and I'm coming right here. She stabilized her forearm on his chest to keep it still. So we've got a nice vice grip there. It's called an anterior-posterior technique. The nice thing I like about this, if I take their helmet off, what's going to happen to their head if we're not careful? It's going to drop back to extension. Their hair is always wet and sweaty already from being inside the helmet. From a stability standpoint, I've got much better control of their head from an anterior-posterior technique, dropping back than medial lateral. Does that make sense? Now, again, this is not a given. What if they got posterior C-spine pain? That may be contraindicated. So I'll still need to practice both techniques, but this right now is for my staff, so I go to, we're going to try the anterior-posterior technique. And once Liz comes here and has this, Ron's got the head, she's going, Ron, I have C-spine, you can release. We're communicating verbally. She's got it. Ron, I've got C-spine, you can release now. So Ron can let go, and he can really take that helmet off. Now we want to make sure we clear the way. We're going to cut the chin strap, not snap it, because if we're going to snap it, we may move their head inadvertently. We're going to cut the chin strap, making sure it's clear. And then we can take it off. So again, we did a T-cut, we exposed the chest, enabled her to come in and get C-spine from the front. She's got control of that. We'll take the helmet off. And then Ron can come back and say, Liz, I've got C-spine control now, you can release. So step by step by step, it takes a minimum of 2 skilled people to take a helmet off effectively. And again, this can be done just as easy in the emergency room, but we need to train the nurses and physicians how to do this. So that may be something to think about too, with the first of the year before football season starts, going to ED and do the in-service. And what we actually do, we videotape it, because most EDs work on shifts. So we usually try to do it in the morning between the first and second shift, but I may lose the third one. So they can video it, and they actually put it on the HR server. So the hospital usually requires that at least once a year, their staff have to come in and check off a document. They watch this video to know how to do it. Shoulder pad removal. Now, from a sequence standpoint, helmet has to come off first, then shoulder pads next. The shoulder pads require a minimum of 3 rescuers. Any way you slice it, I'm going to show you one way you can do it with 2, but typically it really takes 3 people. There's different ways you can do it, and the different techniques require different people. We could definitely do a multi-person lift, and that's what we did with Devon on the field. The people also talk about time. You don't want to be in a hurry, but some people say, well, you're going to delay time in the packaging. From the time Devon went down, and I think Jeff was there, to the time we shut the back door ambulance was 9 minutes. So that really wasn't a lot of time. We didn't delay anything. If we build it in, we're smart, you can actually tie it in. we had to pick him up to get him on the board anyway. So the only thing we said, we're going to pick him up and hold him just a few seconds longer to get his gear off. We communicated on the front. So Drew was calling the head. I was calling the shots from the side. So everybody listen up, we're going to take his gear off. We took his helmet off step by step. He was constantly talked his way through it. Now we're going to take his shoulder pads off. So before we moved him at all, we looked at everything. He had this big rig with the collar and all the different straps. We cut everything, make sure it's completely clear. Now I've got my 8-person lift. I've got 1 person ahead with Drew. I've got 1 person afoot with the board. I've got 3 on either side. I got my paramedic Glenn doing a 9th person come up. And said, Glenn, when we pick him up, we're going to hold him for 12 inches. We're going to stop. His pads are going to fall off. Take the pads off. Pads are clear. Now we can lower it out. We communicated that beforehand. And to get a multi-person lift is a great way to do it if they're supine. It does work for prone. It's an easy way to do it. But again, to take gear off of this takes 9 people. So again, is it realistic in high school? Probably not. It depends on your setting. But for college and professional, it may be a great technique to use. For the ED, this is a great technique to use. You know, we showed this to the ED staff, and they love it. And the one thing about EDs, they got personnel. You think about the number of orderlies and nurses and physicians there, they can easily get 8 or 9 people. And really, they don't have to have, 9 people, because they don't have anybody sliding the board in. So it's very doable. Well, the multi-person lift can be one way you can do it. Another one is bivalve in the pads. The pads are intimidating to take off because you got to get the front and the back. Well, how do you access that? Well, one thing, think about the position they're in. And I used to think, man, if somebody's on their back, that's a bad situation. I don't want that. So how you look is actually a positive. If I've got somebody prone, what do I have access to? Their back. In EMS, we talk about this all the time. That's the most common thing people miss in the primary secondary survey of a supine person. They're going through head to toe. They forget to sweep the back. You have to roll them or do that. When they're on their stomach, I've got access to their back. So while they're there, I can take my shears, cut the back of the jersey, cut the back of their pads. Then when I log roll them over, I'll just cut the front of the pads. They separate easy. So that's actually a positive. So if I can incorporate into this, it really makes a difference. Now, how many have heard of the Rydell Ripcord? That's actually an emergency removal pad system that Rydell developed. There's a guy named Mike Kordecki, who was a long-time athletic trainer, physical therapist for Chicago Bears. And he came up with the idea for emergency pad release. So it's actually got like an emergency guide wire, like a ripcord. And you cut the tab with your scissors, pull it, it separates the pads in the back. Then you cut them in the front, and you simply pull them apart. So easy to do. Now, the elevated torso technique is something that's been done for many years, where it's almost like a sit-up. They take them in the hospital, and they'll grab them on either side, and level them about 30 to 45 degrees, and take the pads off over the top. Now, that's acceptable technique, but one of the things you want to think about there, if we haven't cleared their thoracic or lumbar spine, it's contraindicated, because we're moving them, we may cause some more issues there. There's something called the flat torso technique that I really like. It's very simple to do. It was developed by Eric Schwartz, who's a professor. He used to be in New Hampshire. He's at UMass Lowell now. But all you simply do is slide it out. I've got my person with the front here, John. This is the same C-spot control. So now Ron slid over the side. I've got somebody right here. And all we do is just a flat drag. On the count 3, we're going to slowly slide the pads out. 1, 2, 3. And take them out. Simple technique. Very, very minimal movement. It doesn't incorporate moving them at all. Or if you think about the lift and slide, I've got to physically pick them up off the ground, levitate them. Elevate torso, I've got to pick them up. So this is a simple technique to do. And technically, if you wanted to in the ED, if you're controlled, you could do it with 2 people. You could have one person hold C-spine and the person near the head, take them both and just simply slide them out. It's called the flat torso technique. Again, thinking about what the collar's other considerations, cervical collar, rib pads, back pad. Now, what if you got a situation right here? This is a quarterback pad with a solid breastplate, and that's difficult to cut. And what you can do here, you could do the same thing with a flat torso drag or the elevated torso. You have to go underneath the pads. So Liz is here doing C-spine. She's going to assume C-spine control. She's going to pass it away from VJAC. So once she's got C-spine control, 1 or 2 things we can do the flat torso is simply lift them up, slide them off, make sure we don't catch his face. Or we can do the elevated torso with the paramedics either side, taking him up 30 degrees and then take him off then. We got to think about those considerations. Circle stabilization, one advantage of taking the gear off the field of play is we can put the collar on. Because the reality is with helmet and shoulder pads on, we can't put cervical collar on them. And that's a good way to stabilize their neck. We want to maintain inline stabilization until we can put it on there with full body SMR. Now, another thing is a sort of a controversy, neutral alignment. And this was addressed in the last position statement back in 2009 that Eric Schwartz wrote. If we can, we want to bring them a neutral alignment. And this is a really important concept. I'll tell you why. My spinal cord is protected by my spinal canal. My spinal canal is my widest diameter when I'm in a neutral position. So if I go into extension, it closes. Flexion, it closes. Lateral flexion, rotation. So if they're in a neutral position, they got the most diameter. Remember we used to talk about with the brain, the closed box theory? The skull is bony, it cannot expand. If I have a brain injury, it starts to bleed, it's going to swell to a certain point where it reaches capacity, and then we're going to get ischemia and brain death because it can't expand anymore. The spine is the same way. Devon Gills is a great example. Devon had a C5, C6 injury. So should he have his triceps? Triceps are C7? No. But he has complete tricep. He has sparing because he needed secondary damage. Because with the spinal cord injury, the first thing you worry about is the acute damage. And there's nothing I can do about that. But if they have an incomplete injury, they have the potential to have recovery below there. So if we can package them effectively and not cause any more harm, that may make a big difference. If you're talking about somebody who's going to have a lifetime of care, having the ability to triceps to propel, the wheelchair to pressure relief, to get off their seat, to maneuver around, that's a huge, huge difference. So again, I may not be able to impact anything from the acute injury, but if I can minimize further ischemic changes, so I want to have the biggest canal diameter I can to accommodate for swelling. If he's rotating on the side with a narrow canal, that may cause more problems down the road from a secondary standpoint. So what we want to try to do, if we can, without causing further harm, get you in a neutral position. So as we immobilize him, we're going to take him back to a neutral position unless we meet resistance. You know, I'm not going to try to do a manipulation and bring it back in. But if I can bring him into midline with no increased resistance, I want to bring him back to midline, create a neutral position with a wide canal diameter, and immobilize him there. Spinal muscle restriction. This has been the biggest issue. This was the way to go forever in EMS. Everybody's put on rigid long spine board. Some states, in the state of Florida right now, this is spinal muscle restriction in most ambulances. They're put onto a cot with a collar. And this may be a very effective technique. Scoop stretcher may be a great technique. We use a scoop stretcher. It's a good thing. Now, again, it goes back to equipment. In the state of Georgia, every ambulance carries a scoop stretcher. But the reality is it's not put on there for spine, it's put on for hip. If grandma falls down nursing home and has a hip fracture, it's a great way to pick her up and get her and put her on the litter. It can also be used for spine injuries. Kinder extrication device. How many have heard of a KD before? This is really commonly used in EMS in motor vehicle accidents because if I got somebody sitting in a 90-degree flex position, it's difficult to put them on a long spine board. But I can position behind them. This goes around their heads taped on. This goes around their body underneath their axilla, and we have a series of 3 straps. It's a great technique to use this on. Now, again, it's not necessarily for football, but how many of you covered gymnastics? If you have somebody go down the foam pit, almost invariably they're in a seated position, and it may be difficult to get in there and put a spine board on them, we can immobilize them with a collar and a KD and then transfer them to that. The same thing in a pole vault pit. I've had several instances where somebody went down and missed a pit when in a seated position. This is a very easy way to do it. Vacuum immobilization is not commonly used in the U.S. It's more a European technique. Very rarely in EMS will you see this, primarily because it has a rate of failure. It's a great system from a packaging standpoint, but if you've got a motor vehicle accident, think about the glass around. You know, I'm depending on a vacuum system that can be deflated with a cut, so it's not used very commonly, probably more in athletics than EMS. One of the nice things about this, it conforms to their body and eliminates the pressure points we have with a rigid board. Spinal mobilization techniques. How do I get somebody safely off? Now, Mary Beth Wardysky has done some great studies with this. She's the director of spine research down at the University of Florida. And what they actually did was they took a series of cadavers and they had a neurosurgeon come in, they destabilized them. They actually cut their ligaments at C5, C6 to make their spinal ligaments unstable. And then they put some electromagnetic plate transducers in, and to the millimeter, they can see how much they move in what direction. So then they got trained teams of athlete trainers, paramedics, and physicians, and they practice over and over in the lab, log roll, lift and slide, log roll, lift and slide. What has the most movement? And this has been published actually in several studies now, but these are two of the main ones. What they found out, they moved regardless. Like we talked about before, if you have an unstable C-spine, it's not realistic to think they're going to move to some degree, no matter what care we have. But they move significantly more with the log roll than the lift and slide. So this is good evidence-based medicine. But again, the thing that we got to think about evidence-based medicine, does it fit into reality? So does this mean that we need to lift and slide everybody? It's not realistic, because in US right now, in most EMS, we don't have 8 people there. So in EMS, log roll is still the rule of thumb. That's what is used. And the other thing about lift and slide, it can only be used on a supine person. It can't be used on a prone. I don't want to pick them up, put them face down on the board. So the reality is we have to log roll. So we have to practice it, because 50% of the time we're going to be log rolling somebody. So again, it goes back to healthcare concepts. Know my techniques, practice them all. Know my anterior posterior C-spine technique. Know my medial lateral technique, and then I make a decision on which one I want to do based on the circumstance. Know my log roll. Know my lift and slide. Make a decision based on the circumstances, their location, the personnel. Supine log roll is, again, the gold standard in EMS. I've got one person holding the board. I've got one on the head. The head person is always going to give the commands. I've got 3 people lined up here equally. On the count of 3, we're going to roll them. 1, 2, 3. Going to put the board in at about a 45-degree angle. As they roll them back in, they're going to try to submarine the board underneath them and put them on. If the spine's not neutral, the person in the head can generally correct that, unless they meet resistance, and bring them back in neutral position. Now, the prone log roll. Now, typically what was done in the past is what was taught the pull technique. And how many of you have done this before? It's an awkward technique. If I got a 250-pound guy here and I roll him over, now all his body mass is on my legs on that board pushing down, and you got to sort of scoot out. It's awkward. Also, from a biomechanical standpoint, we always talk about protecting yourself. If I've got a big body, I'm reaching over here, I'm very overextended, it's not a great lifting technique as well. Does that mean we throw it out? If I've got a confined space movement here, that may be the only way I can do it. The push technique is another alternative. If I've got open space, I can put her on this side with the board. I can have my person on the head here, 3 people here. On the count of 3, we're going to push them over. It's a better technique from a biomechanical standpoint. The one thing we have to think about is going to be 2 sequences. I want to push to get the tipping point, stop, reassess my hand position, and then slowly lower them down. So we can do the push technique or the pull technique. Again, care concepts, what's the best on the individual situation. If I've got a baseball player that's ran to the wall, I've got a football player here against the bench, this may be my technique. But if I got open field space, I may have a push technique. The multi-person lift. Again, Mary Beth did some great studies on this, but it requires a minimum of 8 trained rescuers. Rescuer 1 is going to have C-spine here. Rescuer 8 is going to have the board. Rescuer 1 and Rescuer 8 have to communicate, because Lizzie's pushing the board up here, but she can't see where it ends up. So Drew is the head is going to say, hey, let's stop right there with a good technique. My people right here need to be positioned effectively. They want to be kneeling. I can't have people, some squatting, some kneeling, some in a half squat position. They'll need to be symmetrical. Now, the other thing that my board person do here is make sure the spacing is adequate. We use an oversized board. Now, I've seen situations before, they get too narrow and the board won't fit. I don't want to get them up in the air and now the board will fit between their knees. So Liz is going to sit here and say, hey, Dr. Sexton, scoot back a little bit, give me some more space. So we're making sure we got good space. Communicate really, really well. And in the Devon's situation, we actually stopped because it's crowd noise. There's a lot of noise going on. And you've got a lot of people around here. Does everybody understand what we're going to do? Any questions? Are we ready to go? I'd rather take another 10 seconds and make sure when we get up and one person thinks we're moving on the count of 3 and one person thinks something else, or one person thinks we're coming 6 inches and one person thinks we're coming 12. On the count of 3, we're going up. Now, if it's strictly an immobilization technique, we typically go 6 inches. If it's a quick move technique, I want to go 12. And the reason being, the pads are going to fall out. I want to make sure I get space to remove them. So we really communicate with that Devon. We're going to take his pads off. We're going to pause the top. On the count of 3, we're going to go 12, which we're going to hold. Glenn's going to take the pads out. When he says pads are clear, then Drew's going to get the command to lower. and making sure we communicate that step by step. Scoop stretcher. Scoop stretcher is a good technique. It's got some pros and cons. The pro is you don't have to move the athlete at all. We're simply going to line them up. Now, one thing you want to think about, how many of you used a scoop stretcher before? You don't see them as much as they used in the past. Again, most ambulances carry them now for hip fractures, but they're very good for C-spine. The one thing you want to make sure of, these have adjustable pistons here. Adjust the length before you break it. Adjust the length before you break it. How many of us ever had crutches and they've got one crutch on one side long and one crutch short? What's going to happen here, they may be well-meaning, but I've got this on the 4th pin, I've got this on the 5th pin, they don't fit together. So before you break it, adjust the length of patient, then break the hinges. It has hinges on the front and the back. The one thing you want to be careful about here is the top hinge is going to assemble right here. I want to make really careful I don't hit his hands because he's controlling C-spine. So whoever's pushing the hinges to get to the top is going to be very, very careful they don't bump into C-spine. One of the problems with these with pads is sometimes they're difficult to pinch together. If you get somebody's shoulder pads, you're trying to squeeze them in. I've seen this happen in the past. The pads catch in the back and you can't close it. So typically work better on people with less equipment on. But it's a very effective technique. It can only be used on supine people. It's a good technique, scoop stretcher. Now Hartwell actually makes a new one that breaks on the sides here and here. It's a little bit easier to use from that standpoint. KED, again, this may be a great indication using that in the pole vault pit. The vacuum mattress, we have one. We use it more for the curriculum standpoint. I've never used it in real life in a worse situation. It's basically like a giant beanbag. And the nice thing, it does conform, but again, it's not rigid. You can't log roll with this. Lift and slide is a good technique. And again, my concern is failure. If I'm going to use it, I'm going to use it in conjunction still with the rigid immobilization device. Straps and trapping technique. Again, we talked about evidence-based medicine. This is an area that needs more research. You know how many publications there are right now about strapping techniques? In all the 1,500 articles we reviewed, one. Back in 1990, it was two paramedics named Maziski and Matt Malowski, two paramedics in Los Angeles. But what they talked about was a really important concept, the X-strap technique. Now, how many of you drove over here today? Okay, if you punch the gas real hard, what happens to your body? Go back. If you hit the brakes real hard, what happens to your body? You go forward. Now think about this guy right here. He's in athletic gear that's made of nylon. It's wet from exercise. It's sweaty. I put him on a plastic board and I put a strap around his thighs, a strap around his waist, a strap around his armpits. Then I take tape and 2 points of contact and I tape his head really tight to there. What's going to happen in the ambulance when they start, stop, his body's going to piston back and forth. His head is really secure. So actually what I'm doing is traction, distraction, traction, distraction. How can I eliminate that? Is what they call an X-strap technique. If I take a strap and put it right under his axle and go across the other shoulder and a strap right here, it eliminates his body from pistoning back and forth on the board. Now traditionally, this is what's typically used in the EMS is a 3-strap technique. So let's think about multiple straps. I take the X-strap right here, and we use a pin system with speed clips, so it takes a custom board with a steel pin in there. But again, these work really well on really any size person, and they're adaptable. So I take a strap here, strap the right X. I can strap his pelvis. If I want to, I can take an X strap across there too, because there's a lot of body mass there. Get their femur, get their tibia. So that's 7 straps, but he's much more secure. He's not going to piss on the board. Spider straps work the same way. How many of you use spider straps? Spider straps are like a parachute. It's really good if it's packed effectively. But this is about 20 feet of Velcro. And you want to talk about like a Rubik's Cubes, if you walk in there and you get 20 feet of Velcro wadded up, so then you're just going to spend 15 minutes trying to get your straps undone. So it's like anything else, we want to check our gear and make sure they're packed effectively. But either one of these are great techniques to mobilize and prevent the pistoning on the board. Another concept we think about with strapping is body first, head last. Body first, head last. The reason for that, the body's all the mass. I want to control that. The head's relatively light. What if they have a concomitant head injury in the middle of Pakistan and start to vomit? I've got to roll them on the side to get their airway. If I have their head strapped first real securely, I'm trying to hold their body, I'm going to cause more movement and trauma. But if their body's strapped, I can control their head very easily with my hands. Securing the head with 2 points of contact, one landmark is the eyebrows, one is the chin. And there's a variety of head immobilization devices you can use. The biggest recommendation is nothing weighted. In the past, we used to use sandbags, and boy, they'll secure your head really well. But again, if they vomit, we have to roll on the side, I'm going to cause movement. So I want to use something really light, like a foam block. Transport to medical facility, find a definitive one for spinal cord injuries. Think about situation too, what anticipates worst case scenario. How many ever had a combative athlete? Scary. How do you handle that? And if you think about it, somebody's not their conscious officer, they wake up, there's 8 people around them, somebody's holding their head down. It's scary, and they start trying to move and fight. There's different rationales for this. The positive thing is just like when I'm doing my secondary survey, I'm running out there on the field, my scene assessment, if they're moving, yelling, I feel a little bit about it. If he's sitting there punching on me, what do I know about from a neurological standpoint? I feel a little bit better than I was when he was unconscious. But can we potentially cause more harm by trying to hold him down and force him if we can get him to relax and sit up and clear him? So again, there's not a right or wrong way, but talk about it. That's where your physician EMS, if we had an athlete come to combative, how are we going to manage that? CPR, pads have to come off. This is not a spinal cord injury anymore. This is a resuscitation emergency. Cardiac takes priority over everything else. So the pads have to come off. I cannot do convective oppressions and defibrillation with the pads on. Helmet's got to come off. Confined space, having a plan. In this one, multi-person lift's not going to work. Log roll's not going to work. Log roll push is not going to work. I'm going to have to do the log roll pull. So take home points again. Have an emergency action plan, have a C-spine plan, a protocol that I've talked about in advance with my neurosurgeon, my head team physician, EMS, we're on the same page. There's not a right or wrong way. And that's the one take-home point for this. I don't want anybody to walk away and say, run ahead and take the gear off on the field of play. That's not the purpose of this. The purpose is the gear has to come off at some point. We have to make the decision the best place to do it and make sure that wherever it's done, whether it's in the ED or on the field of play, has been done properly by trained, experienced people. Practice, 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 scenario-based practice. And the team concept. We all got to work together. If we get too many chiefs and not enough Indians, we're going to have a bad outcome here. It goes back to team. Why do successful teams win and excel? Because they practice scenario-based. Why do sports medicine teams excel? Because they practice scenario-based. Thank you. Any questions? Daryl, I know you're always going to have one. Does that make sense? Yes, ma'am.
When is that video going to be available?
NATA. What's going to happen right now, everything is pretty much done. The papers are written. They've been accepted. They're copy edited now. The video, we're in the final editing and put the narration in, but everything's set. It's all embargoed right now. And the reason for that is when you're publishing in 4 journals, everybody's protective and one doesn't want the scoop on the other one. So the journals are going to come out right before NATA. We're going to have a press conference the first day at NATA and release everything. The video will come out then. And there's actually going to be 2 presentations. Several of the people on the committee are going to be there. We're going to do one on the Delphi project. We're going to know the best practices, and we're actually going to have a lab that I know Daryl and several others involved in. That's going to be where I think 150 people can sign up. We'll actually do some hands-on with that as well. And then the next thing is get the information out. So we've got a plan over the next year. Right now, we've got 24 presentations scheduled already. We're going to do it at every district meeting. We're going to go to AMSSM, AOSSM, North Medicine Spine Society, Don Joy, CATS, National EMS Symposium. What we're trying to do is pick the best venue we can do to get the information out. Yes?
Is that video going to show the Courson ice hockey equipment too, or just football?
Great question. Daryl actually raised that point today. Right now, we're starting with football. And actually, the paper is the management C-spine in American tackle football. Now, I know that doesn't cover everything. But we decided initially we wanted to go to the main audience and break out from there. So we're going to have some spin-off projects. We've already talked about gymnastics. We talked about lacrosse. So there's going to be some more papers coming out of that. There's going to be some more videos coming out of that as well. And what we're going to do as well, and we're still working on the logistics of this, is probably going to go through NATA. We're going to have a repository. So we won't have information out here. So again, rather than trying to recreate the wheel, you can go to the NATA website. The articles will be there. The video will be there. We'll have a sample trauma bag with equipment supplies. We'll have a sample spine board kit. We'll have a sample emergency action plan. We'll have a sample crisis management plan. Have a sample C-spine protocol. So again, if you're trying to make a new one, you can take a look at that and pick and choose from there. So those will all be available as well. Any more questions for the Northern Peninsula?
All right, then we would like to thank our Courson for the great talk. Just a couple of announcements. Please turn your evaluations at the back. You can also pick up your CEU certificates. And if you are a student in our athletic training program, please come up here so we can take a picture. And other than that, yeah, I was supposed to say that. Last name, please place your children. Have a great afternoon.